So it's my pleasure to toss this to Bob Glover, the Executive Director for NASMHPD. I know that all of you probably met with Bob before, but maybe not. And some of you, I think, are new to your positions and perhaps have not been to a meeting of the National Association of State Mental Health Program Directors. Bob and I have a long history together. Seems to gets longer every day. And so I served as the mental health commissioner in Nebraska, and went through new commissioner orientation and everything with Bob. But we actually had known each other before that because I had done some work along with some other people around some rural mental health issues through the NTAC. The National Technical Assistance Center, which is related to NASMHPD. So even before I was a director, I had worked a little bit with NASMHPD. So it's a pleasure to have you join us, Bob, and I'll toss this to you. And it's great having you here with us virtually. And you missed a hell of a windstorm yesterday.
We got our share here. Thanks, Dennis. I want to thank Dennis and all his staff. It's great to partner with WICHE. It's really a great relationship that's developed over the decades. And it's also, pardon me, good to see all of you there. And we take an opportunity. I was there last year, and if I didn't have what was going on the Hill, and I'll update you on that in just a minute, I was going to be out there. We did have a snowstorm. They don't know how to handle it here in D.C., I've got to tell you. 3 inches of snow and everything stopped. But Meg and I made it in regardless, and I would let you know we would normally do a more polished PowerPoint, but this will give me a chance to give you an update, and I'll do a lot of reading because I want to address 3 issues today with you, 2 in somewhat detail. First, what's going on the Hill, and with the anniversary coming up of Newtown shootings, etc., and a lot of attention the media is doing, you're going to hear some stuff over the next couple of days that I want to give you some heads up on as that moves ahead. Then I'll talk briefly about what we're doing around a report NASMHPD's putting together in terms of the role of state hospitals. Our board and our members felt we needed to really address that issue, and I'll give you an update on where that is. And I know in the western states in particular, those hospital roles are very significant. We've got Corey and others there that have run those facilities. And we had a good meeting, and we're going to be coming out with a technical report on that, and I'll give you a little update on that. The third one that I'm hoping, and this is I know you are having it, Dennis, on your agenda, is data and what's going on. And we are, the NASMHPD and NASDAD are having a joint meeting tomorrow with SAMHSA. I'm going to share some misgivings as well, but also some, I hope, direction on where we're going with that. And Charlie, I hope you'll understand what it says here stays here in some sense, because I want to be pretty candid and get feedback from you state people on some issues where SAMHSA has proposed ahead and what are its implications. We're going to have an opportunity to air those concerns, but also work with SAMHSA positively in the long run. And I can tell you, well, I'll save that discussion, and then that's really when I want some interaction between all of you. So, Dennis, if that's all right with that agenda, can I move ahead?
Absolutely. Take your time.
You all can hear me okay?
Yeah.
I'd like to say hi to everybody, but I think I appreciate the introductions around the table. I'm going to use the USA Today article that just came out, which talks about USA has made slight progress on mental health since Newtown, okay? And the headlines are, the advocates for mentally ill say that there's been fitful progress in the year since the shootings at Sandy Hook Elementary School turned the attention to failures of the mental health system. Then it talks about, NAMI says 36 states increased funding for mental health. Then Fuller Torrey from the Treatment Advocacy Center talked about lawmakers in nearly a dozen states strengthened laws that could allow more people to receive court-ordered treatment for symptoms of severe mental illness. And that's going to be woven into what I'm going to talk about in just a minute. And the White House, as Dennis noted, as yesterday promised $100 million to increase access to quality services. And I'll go into that a little bit. Later on, they used NRI's data talking about the states made $4.35 billion cuts, and really what they're putting in is not offsetting that level of cuts. And then some people, NRA, the National Rifle Association, talked about, and I'll remind you, the way to prevent future atrocities with a lot more mentally ill people up in psych hospitals. If they leave these homicidal maniacs on the streets, they're going to kill. They need to be committed. I would also tell you that the county behavioral health group noted that congressional efforts to improve mental health, which were attached to an amendment to the gun control legislation, have been in limbo ever since the gun control bill failed. So that's kind of a macro, what's bubbling and kind of what's going to occur. Let me talk briefly a little more on the Vice President's announcement, and to let you know that there was $100 million in new spending, and this was yesterday. I'm not sure they were trying. I think they know that tomorrow Representative Murphy is going to have a press release. He's a Republican House representative who's been holding hearings on SAMHSA. And he's going to roll out a 12-point initiative that I'll talk about in a minute. But it was really important, I think, that the White House came out and talked about the $100 million new spending for mental health, and it's allocated part of it through HHS and the Department of Agriculture. It's kind of an interesting mix. But I would tell you that half the funding goes to community health centers, not mental health centers, community health centers, for expanded behavioral health services for people living with mental illness and addiction. And the centers can use the funding to hire new mental health professionals and add mental health and substance abuse services. So there's part of it. And the other $50 million is going to go to agriculture and to be used for constructing, expanding, or implementing mental health facilities in rural areas over the next 3 years, or providing telemedicine care for those living far from a health provider. So that's kind of the initiative that was announced yesterday out of the Vice President's office. I would tell you that the program money will be allocated to regional governments like county health and welfare departments, as I mentioned, to expand mental health in rural schools and other community settings, and again, potentially using telehealth as part of that. Now, you think about that discussion, and now we're going to a release. It's going to be tomorrow. It's going to be a press release, as I mentioned, and only press are invited to this press release, which is, I think, they strategically realize that the proposals they're going to be making are that there are groups that are going to have real problems with parts of each. Parts of the 12 I'll go through quickly here in a minute. Consumer groups have problems with some of it. Some provider groups have problems with some of it. Legal representatives in terms of access to data information is all composed in this. Right now, it looks like there's going to be 12 titles in this about 170-page draft bill. Okay, Murphy's bill. Pardon me. And if you think about the timing, this is done intentionally around the anniversary date. I'm going to tell you a little later that the Democrats have actually come out against it officially, or not officially, they're going to wait till it is, but I think Murphy was hoping to get some bipartisan support in the House. I'm not sure it's going to be there, so I don't know what the likelihood of this moving significantly, but I think when you hear the components, it'll give you an idea of kind of what's happening on the Hill and how they're looking at this issue. Let me actually give you, they talked about it originally as 4 components. One, an early intervention component, a treatment component, an IMD component, and HIPAA reforms. I would say there's a real major stress in terms of outpatient civil commitment. Assisted outpatient treatment is what they're calling it. Involuntary outpatient commitment, as most of you know that title. But now let me talk about each of these in some detail. I think expressing some concern Murphy has with the current management of SAMHSA, they're talking about an administrative reform, creating an assistant secretary for mental health and substance abuse disorder, and that'd be the equivalent of an assistant secretary for health, which would report directly to the secretary of HHS, with some discretion to shift funds among HHS. And they also wanted to support an interagency severe mental illness coordinating committee based on the autism interagency model. I've got to tell you, I'm not up to date on that, and some of you may have more knowledge of how that's functioning at the federal level. Like I say, I don't know that this one's going to really get legs, but we need to be aware of kind of that interagency autism model. There also will be some first aid provisions in there. I think it's going to be like a demonstration for that, not as big as what the National Council was hoping for. I would tell you that's the first, administrative reforms. And what I think Murphy's done was try to get to each of the significant entities, including they approached us on the IMD, and see if we could support at least that part of what's coming out. And I'll go over kind of where that is. Now, the second one is, in fact, mental health block grant reforms. I would tell you, originally they were talking about transferring the mental health block grant, not necessarily the substance abuse, but the mental health block grant over to NIMH. And a lot of us said, whoa, wait a minute. NIMH has a very different role responsibility. We're service delivery, they're research, and that's not a good marriage as far as we're concerned. I would let you know that I believe, and I've got a draft, I haven't had a chance to look at the latest 170 pages of it, but I believe now they're talking about transferring the block grant, not to NIMH, but under the control of that assistant secretary for mental health and substance abuse, okay, under that direct control. Now, in it, there are some things that were real problematic with the block grant that I want to go over with you. And I'm not sure this is actually legal, and we are looking at it, but they talked about putting additional conditions that would be placed on states. And I want you to listen to this closely. States would not get their mental health block grant unless they had assisted outpatient treatment laws on the book or were working towards that. Now, what does that tell you? That this committee has felt and been listening very closely to Fuller Torrey and his positioning around insufficient psych hospital beds in the nation, and the difficulty of getting people in against their will into facilities, and the difficulty of providing services with conditional release once they're discharged. So that's kind of this big, what would I call it, scheme that Fuller and the Treatment Advocacy Center are saying that, and that by addressing having more assistive outpatient treatment, where people would involuntarily comply, and if they didn't comply with what was done, they would be put back in a state hospital, was one of the conditions that he felt was necessary. That's getting a whole lot of attention from the non-clinical people on the Hill. Now, besides having that assistive outpatient treatment, and well, let me talk about that a little further. They are using the New York intervention out of Kendra's law and other issues, where New York has put a whole lot of money into their outpatient, involuntary outpatient commitment, and have done some studies in it, and some of the initial evaluations look like it has reduced the incidence of individuals who've been doing violent acts. But I would tell you it's very expensive and with rich resources in the community. And to automatically think that that is the model that would work in Montana or other places, I think is naive. But clearly, at the federal level, some people feel that every state ought to have this involuntary outpatient commitment, and that it ought to be used, because they're very much aware that there are only about 5 or 6 states that really assertively use this in a program sense, and they're really thinking that it should be used more often. They also are talking about a new 5% block grant set aside for early psychosis programs. And they're looking at the raised clinical trials and the neuropsychology of the prodromal psychosis issues, so that some of those programs that are being tested out in the communities are used as all states ought to have some preventive early intervention issues as part of. That was all under still the Mental Health Block Grant. There's a section on Excellence in Mental Health Act where it talks about facilities, renaming the community mental health clinics, et cetera, and Medicaid being available there. There's a section on HIPAA reform, which is talking about providers can share confidential clinical information with immediate care providers. And I put parenthetically, that would be family members. And let me tell you that if a person with severe and persistent mental illness lacks judgment, and sharing the information would be in the best interest of the patient. Now, as you might guess, there's a whole lot of people, Bazelon Center and others, DOJ, that are kind of watching this closely, and I think as I go through this, you can see where they've enticed groups to look at parts of the puzzle and can endorse some of it, but not all of it. Okay. There's also funding, the fifth is a Department of Justice reform, and it's a new grant for counties that have AOT, listen to that, but aren't using them. Interesting way to put it. And it's, these grants would be used to specifically train police officers on how to recognize mental illness. They're talking about 2 GAO reports, one seeking to estimate the number of people with severe mental illness in penal systems, and a second report on the cost of treating those individuals in penal systems. So that here's another component as you're looking at how they're putting this collage together. Now there's a specific addressing of the Medicaid reform IMD issue. What I'm going to tell you is, what's that noise, Megan? That IMD issue keeps popping up. When Murphy started looking at trying to repeal totally the IMD, they realized that in several states and over the duration of that reduction that's proposed in the law, that's billions of dollars, not millions, billions, and that would be budget busting. And they're trying, this should not surprise you, they're trying to minimize the amount of new money they have to commit to these issues, and are taking some money from one area, for example, I'll talk about it, the PAMI protection advocate issue, and proposing that be put like at NIMH for research. So that they're trying to hold new costs down, and but still present a significant, I put in some quotes, comprehensive initiative. Again, they talked about Medicaid reimbursement for behavioral health, telemedicine as being part of Medicaid reform. They're talking about something like a PTSD program for Medicaid recipients with mental illness, where physicians will be trained in how to screen for mental disorders, which would trigger reimbursement for some treatment for conditions discovered in the screen. So CMS and others are trying to figure out what role that would be played, and these Medicaid issues are there. I would let you know that the Medicaid directors did support repeal of the IMD for the people that are 21 to 64, feeling that was discriminatory. I think they, unlike Medicaid at the national level, are representing their state interests and realize that how damaging this can be to some of your states and others around the nation. Hundreds of millions and literally $2 billion just for this next year, it looks like, as we look at it. The next issue will be NIMH funding. Now, here there are kind of three major areas they're proposing in this legislation. And I'm telling you that this is a hurried analysis, so I don't want you to hold my feet to the fire. This is the exact wording that comes out, because it's embargoed, and there have been some changes that have been made this morning that I was talking with some people about, and there'll be a few more probably before tomorrow. But Another issue will be NIMH funding for increases in looking at violence and mental illness, okay? Additional brain research and partnering with pharma to spur the development of new drugs, in particular to deal with the behaviors that they see link people with mental illness and substance abuse. But I would tell you that substance abuse, you haven't heard me use that term much at all, but those of you that know, these kinds of behaviors are elevated when people have substance abuse histories as well as mental illness for the few that do the kinds of things that occur. There's a discussion around the Department of Education and anti-stigma programming, spreading information about mental illness and reducing stigma via social media networks. There's a behavioral health HIT bill, not any new money that I see related to mental health for us in there. There's another section on volunteer doctors bill, which is a liability protection for physicians volunteering to work in FQHCs and CMHCs. So one way to try and protect their liability. One that SAMHSA's reform and reauthorization specifically that was in, and I'm hoping it's gotten changed, but I'm not sure, is that the current appropriation for the PAMI program, you may not know this, is about $36 million. They want to cut its budget authority to $5 million, and in fact put in legislative language prohibiting any of those people from lobbying. This stems, I think, from a feeling on Murphy's committee and some of the staffers that that program, the Protection Advocacy Program that's out there in each of the states, there have been some alleged, I don't know this for a fact, but they say that some of the people have gone in and lobbied, which is not part of their specific role, and they felt that that's inappropriate, and that they, in fact, at one point in time, I don't know if it's still true, the transfer of those funds would, I think, they talk about that going over to NIMH. You can see kind of an offset dollar. Clearly, Kurt Decker and his crew are real concerned about what that means, and a lot of consumers are concerned about where that goes. The Garrett Lee Smith issue dealing with suicides would be reauthorized. There's some protected class issues. I'm not sure where that's going. So there will be, as I mentioned, a press meeting tomorrow morning with only the press or their credentialed press, actually, which, as I mentioned, is unusual. I think they don't want anybody taking issue with it. Clearly, they tried to entice us by talking about here's a way to look at IMD, and let me actually, since it's so important, a couple of you, let me tell you about what they're looking there. This section of the bill would provide states with the option of receiving federal Medicaid matching payments for Medicaid enrollees between the ages of 21 and 64. Remember that. That's where it's currently on it. You're not able to do that. Receiving short-term acute psychiatric hospital care in a freestanding psych hospital or an acute care unit of a state-operated psychiatric hospital, which has a facility-wide average length of stay of less than 30 days. I don't need to go into the background, but most of you know the IMD exclusion was part of the original Medicaid program enacted in 1965. And the definition then was an IMD is a hospital, nursing home, or other facility of more than 16 beds that is primarily engaged in providing diagnosis, etc., for individuals with mental disease. So the private sector, Mark Koval is interested in this, representing the private hospitals. It is not a total repeal. It would be looking at inpatient in state hospitals that currently and the units actually within the state hospital, not the hospital-wide, but a particular unit, that it would have less than 30 days. I think at the Murphy realized that if, and there are ways to gain this, I've got to tell you, we talked about that with him, but he didn't want to have the appearance that he was embracing going back to the old concept of institutions 100 years ago, and also it was a budget buster anyways. let me stop with that one, see if you have any questions or any, and I've got to be conscious of time. How much time did you have me in here for, Dennis? Well, whatever it was, Dennis, I'm glad you stayed for it.
Till 9:30, till 11:30 your time.
9:30. Another half hour.
Okay. Any comments regarding that? Any reflections that you have? Anything that you'd like us to be aware of, or anything you've been hearing in your states around kind of the anniversary coming up, or what may be what you may be hearing? And you'll have to speak up because Dennis was going to moderate. I can't see you well enough to know who's talking yet.
So Bob, I have a question. This is Carl.
Carl.
How are you?
I'm doing all right, given what's happening here, you can tell.
Great. So my question is, if they start tinkering with the IMD law, how is that going to affect the role of the emergency rooms in hospitals and their obligation to go ahead and have people committed to beds when that's necessary, or provide services when it's necessary to the mentally ill?
You know, Carl, I didn't see a component that addressed that, so I can't answer it. If you think about what he's proposed, it is so comprehensive at one level, but spotty, and it's still 170 pages long. And what happens with these bills, if they ever get enacted, there's the very gross and then more fine-tuning that goes on, everything, you know, dealing with rules and regs, and then interim rules and regs, and then final, so that, what is that, Megan? We have something showing on our screen, I'm sorry. So I can't answer that, but I'm making note of that, and I'll see what is there, all right?
Great, thank you.
Okay. I would also tell you, before we go into the state hospital, that SAMHSA just recently had, and maybe some of you saw it or participated in, they had a seminar on assistive outpatient treatment. It was December 2nd, and they had hookup capability. And they had some people, Marvin Schwartz, who's a professor at Duke University, and Jeff Swanson, who reported on what's going on and some of the reality around assistive outpatient treatment. I think SAMHSA and Pam have realized that this is an issue you can't ignore, and in fact, given that a lot of what happens is under your review in the states and SAMHSA at the regional level around these issues, we need to be more aware. SAMHSA, and Charlie, you may has not taken a formal position on this that I'm aware of. I think the last time I talked with Pam, she thought that maybe there ought to be some studies of it beyond the New York issues. So, Charlie, do you have anything on that?
Bob, I don't. And I agree with you. SAMHSA has not taken an official position on assisted outpatient treatment, but we are encouraging those dialogues and continued examination.
Okay, thanks. The next one I want to get into is, and just tell you that we had representatives from a variety of states working on the vital role of state hospitals and kind of looking not only just currently, but where they ought to be. And I'm going to read you who attended it. And this has been a long-term effort to bring together enough experts in a variety of roles who then spent 2 days in California discussing a lot of issues, including NRI provided an exceptional amount of good background data on some of the changes that have been occurring in our facilities, how historically the downsizing and numbers reduction and kind of where things are going in the future for those states that provided information. So I really want to let you, and I want to thank NRI for that. But the following people were there, and I would tell you, Corey Nelson would have been there, but wasn't able to, and we missed you, Corey. Mike Maples and others. We had, because the Western Psych Hospital meeting was convening out there. We took advantage of asking for 8 representatives. So we had the Western region, we had hospitals, 8 or 9 of them, Alaska, etc. We had the regional chair, Dallas Earnshaw, superintendent of Utah, the Midwest Association. We had the regional chair, Bill Gibson from Lincoln. We had the Southern Regional State Hospital Association represented, and Jim Smith from Texas was there. We had the Northeast Regional representation, and Pat Canavan from St. East was there. We had the medical directors, Alan Radke and Joe Parks, and Joe in particular was helpful to process and facilitate the meeting. We had Kathy Warburton and others from California, and I want to talk about that specifically because it raised some issues that we find we need to address. We had Idaho State Hospital, we had New Mexico, we had Oregon, Greg Roberts, we had Ron Adler from Washington, we had consumer groups, John Allen, we had housing expert Kevin Martone, who used to be a past commissioner in New Jersey and is now the head of the tax center there, doing great work from Trailer on housing. The Research Institute was represented by Vera, and Ted put together some nice information for us on that as well. And then Megan, David, and Brian Sims, a forensic psychiatrist, myself, were there. Megan has taken some lead on putting together the report. Out of that meeting, there were probably more than 100 recommendations. They've been refined, culled, put together, and the second round, they've been sent out to members that attended the meeting for review and comment. We anticipate all of those will be incorporated by mid-January, with the first draft going out in February to all of the group. Now, I want you to know that the board in particular was hoping to see interim information on this, and we wanted to protect the fidelity of the process. Those of you that have been involved in this, you know that we can only make recommendations that occur in the meeting and that have been discussed. So we don't add on issues. And although some people wanted to do that, we said no. The fidelity of this report and how we do it is and the process is that. Now, I would tell you that some of the feedback we got is I think was informative to me and Megan and Joe Parks and others that are working on trying to put this together. In the forensic component, well, I would say those people that are dealing with people who are really violent, they may have mental illness as well, and there's another group who are perpetrators who are maybe not mentally ill, but they end up in our systems and they're looking for victims, and that some of the values that we espoused and the principles around trauma-informed care, etc., were not as easily embraced in some of the facilities where you're trying to deal with psychopathy and other issues that are not amenable, and we don't know how to address as readily as we can with the therapeutic kind of interventions that we are aware of now. We don't want those values overall to be lost, but we feel there's a subcomponent, and I don't mean this pejoratively, of individuals that are in some psych hospitals that are pretty dangerous, in fact lethal in some cases, and that we've got to address that in an additive way and not leave it out. So it was informative as we worked on this. I want that more as FYI, because I know a lot of you, in particular out in the western states, the state hospitals play a very core central role, and this document we feel will be very important, not only for the facilities themselves, but for the state directors, because you'll get a copy, and you can use that as you deal with your state hospitals, as well as recommendations for NASHMPD, their recommendations for CMS, their recommendations for NMH, and other things. So that's a preview of things to come, but knowing that how important inpatient is for you folks, I thought it would be important for you to hear that. Let me, rather than open it up for discussion, let me go to the last one, which I think is where I hope I can get some feedback from you. We will be having a performance measurement work group meeting with SAMHSA tomorrow, and I'll read out who's the members of that work group in a minute. And I'm going to express some frustration, but I'm hearing more attention being paid now. Our members, NASHMHPD put together a group of commissioners and others to represent your interests coming into DC tomorrow, and most of them there were flying in now. And NASDAD has a group of single state authorities and interested people flying in as well. And we're jointly meeting with Pete Delaney and his group to talk about where data ought to go in the future. Now, what I'm going to do in a minute is I'm going to tell you a little bit about the discussion we had in the board. I'm going to tell you a little bit about the discussion that we had in preparation for the performance measurement work group coming up, in preparation for that. And then the real question that I'd like to hear from you are concerns and opportunities. I don't want to talk about just kind of the concerns of the reporting burden, but I want to hear about and think longer term where we ought to be going, what strategies we ought to be thinking about. Maybe it relates to Medicaid and knowing what billable, et cetera. So let me have that in your mind, and I hope Dennis is back and can help us process some of your comments, because I'll take notes and be able to carry that to the group. Let me tell you who's on the performance measurement, then I'll go through the discussion with the board briefly, and then a little bit on what the 1 hour call prep was with the getting ready for tomorrow. The group's made up of Commissioner Scott Adams, as you know, maybe don't know, but he's from Nebraska, Brian Hepburn from Maryland, Mike Maples from Texas, Steve Barron from DC Director, Linda Zeller from Michigan. Now, as well, we've got state mental health data staff, Kevin Campbell from Washington, John Collins from Oregon. We've got Kevin Conley from New York. We've got, let's see, Clive is from Missouri, Woodward, Mary Smith from Illinois, Sue Loomis from Indiana. We've got a couple of state mental health planners because, as you know, that block grant data and their planning groups to deal with it. And we've got a state planner from New Jersey and one from Ohio. We've got the Office of Consumer Affairs from New York, John Allen and others. Myself and NRI will be represented. So that group plus NASDAD's group are coming together. We've had staff discussions about both of those roles. NASDAD had its own board review of what the implications for an integrated mental health data, behavioral health data system. Okay, so that's kind of at the SAMHSA level. They're looking at this across mental health and substance abuse. Now, at our board meeting December 3rd, we talked about the work group and kind of what the board's concerns were, and they wanted to make sure, and I'm going to put this in positive, affirmative as best I can, because there was some concern, but also wanting to know that the block grant was important. We needed to provide block grant information, which is used on the Hill, and the increasing importance of Medicaid, and kind of we need to make sure that we are dealing with CMS both directly, as you do in your states, and NASHMHPD and NRI do that, as well as with SAMHSA, and that Medicaid link has to be part of part of our strategy, and that clearly we've been working with Mark, I'm sorry, the Medicaid, my counterpart.
Matt Salo.
I'm sorry, Matt Salo, I'm thinking Mark Cabal. Matt Salo, over at the Medicaid directors with discussions around this. And that we wanted to be part of a solution and not just whine about what isn't working. The board talked about that. The people also talked about there needed to be better link between substance use and mental health, and that the TEDS data had some use to them, and those are states that have both substance use and mental health in the same department, so we were getting their insights onto what worked and what didn't in the TEDS area. They really talked about making sure that we address the links with healthcare specifically. If we look at why people are failing in our system, it isn't always the psychiatric component. It's frequently a combination of that with physical issues, obesity, smoking, substance abuse, etc. So diabetes, etc. We talked about that. We needed to talk about tying the data into a multi-payer strategy, knowing that Medicaid spends a lot, so that the claims data and kind of encounter data is really important. Clearly that's not being collected right now in any significance at SAMHSA, but clearly our members felt as you folks manage these, that's some information, and this is looking longer term, that we think we all need to be part of and have access. So kind of that future role of where we go, some discussions about being proactive and not whining again. It was really important that this, one of the things I was trying to drive home with SAMHSA, they've had a 1.5-year process in-house trying to figure out the strategies on where they're going with limited state input, both from mental health and substance abuse. And I checked with NASDAD, and they feel the same way, and that some of what they proposed is naive and non-responsive to what you folks need as you manage your systems, and that finally they've identified some funding and a vehicle to do it, to bring our groups together. Now I think I'm through venting how much I've had to hammer on this issue, and now we hope by having this meeting coming up that there will be some attention and voices heard. One of the things I want to hear from you in just a minute is kind of some concerns you may have around data collection, both block grant and larger. There was some discussion about should you only look at the block grant, since that's what SAMHSA has authority around, versus the full public mental health system. Let's see, what else did I want to go over on that? Getting ready. Actually, let me, hold on, I think there are. Let me highlight a couple of issues that came up for the performance discussion. Measurement group. Back again, block grants, very important, but a small 1% of the total state and mental health authorities, and that Medicaid has to be part of that. They're worried about the admission to discharge paradigm that the substance use TED use, which doesn't adequately reflect kind of the long-term nature of the mental health services. I don't need to go over that with you much, but clearly a lot of the people you serve stay longer than 1 month, and to look for changes on a monthly basis is kind of burdensome and maybe not realistic, and that monthly, and now I think they're talking not monthly but quarterly reporting is, I think, where they're currently looking. So we've got them to think about at least stepping back a little from that. Another thing, I think I've heard them, and I'll know for sure when they make this announcement tomorrow, that they're talking about not making significant changes for the next 2 years, but use that time to get us all together, working together moving forward. Clearly, the state mental health authorities and the people who were on this work group talked about Medicaid and identifying meaningful measures for future use that reflect the integration of behavioral health. Now, I've got to tell you that some of the substance abuse field is not as enthused about that integration, but on our side, our members actually talked about it, supported, realized that to be part of the larger ACA, et cetera, and to be part of that system, we need to be working and having the data together. New systems have got to address stuff like behavioral health homes, dual diagnosis demos, EHR, meaningful use criteria, et cetera, and that we need to be thinking about that. I tell you, one issue that really came up is the important role that we think NRI plays for our side. NASMHPD doesn't have a counterpart to the NASMHPD Research Institute, but we really know how much they've done, not only with the community side, but with the state hospitals and performance measurement system there. If it's all right, Dennis, I'd like to stop now and get comments from all of you, and Megan, if you wouldn't mind catching this, all right? Comments in particular around the data and concerns as well as opportunities, so we can talk about what we may jointly work on with SAMHSA over the next several years. They did make a commitment to have an annual convening of this group, as well as needed if there are emergency issues that come up where maybe Medicaid comes up with a new measurement that we're not sure about. So I want you to know I see the beginnings of a good partnership process.
Okay, well, thanks, Bob, and I guess we'll start off with some with you providing Bob some input. Let's start with the data end of things. Does anybody have something they want to offer Bob? There's some thoughts about this.
Hey, Bob, it's Patrick from Colorado. Hi, Bob. We're in the process of pretty ambitious 2.5 year data integration, and what we're really doing is looking at what are the requirements. We have a separation between the office that manages behavioral health Medicaid dollars and general fund and block grant. And as we try and streamline encounter forms, we're creating these documents that have the immutable data requirements and specific fields. And what we're noticing is that there are some areas of overlap where CMS is asking of healthcare policy and financing in our state certain encounter level data, but that the SAMHSA block grants have very different specific requirements. And we're trying to then say, for instance, instead of having 2 different encounter forms, each with 15 questions to serve different masters, can we create one unified form that that our providers can fill out that would then extract data to send to the different masters? And I guess just as we're sitting down at the table trying to figure out what the data requirements are and ways in which we can streamline them, is there any effort on the part of CMS and SAMHSA to do the same? Are there areas where block grant requests for information and CMS requests are similar enough that they could use the same measure? So that we don't have a whole bunch of different demands floating around. Because from the provider level, when you're down in an office, and this is going to become even more important when we get to integration, because the primary care practitioners who are going to be asked to enter in some behavioral health related issues, I think they're going to be tackling this begrudgingly. And if we say you have to complete this encounter form for medical Medicaid reimbursement, this encounter form for what remains a block grant, and this encounter form for behavioral health, they're going to throw up their arms and say we don't have the time for it. So if there's a way to sort of create one encounter form, or to at least reduce the redundancy and all pull in the same direction, I think would be helpful.
Yeah, I sure appreciate that. And in fact, we had originally meetings set up with CMS to have that particular discussion. Then the questionable rollout of enrollment, and everybody's just swamped, as you might guess, trying to make it. But this has implications just for the enrollment process, literally, I think. So that your comment will take to SAMHSA as well as when we meet with CMS, so thank you. I do, and you made me think, I left out one that's terribly important. The commissioners on the board in particular, but also the performance measurement group, talked about needing to have measures that look at recovery and outcome, and that they may be very different on the substance abuse side than they're on the mental health, but we need some, and not to throw those out. just looking at process or descriptions of service delivery. So that I think this is a complex picture. I'm glad that I think they have backed off quite as quick an implementation and are saying now, okay, we're going to consider what's the reality of trying to implement this stuff in the state with not new money. You know, there's no new money. They've got the dig, and that's about it. And we know, in fact, a couple of states said some of what was proposed would cost more than what the block grant total budget is. So that I think there's some reality at looking at it and knowing that it's going to take goodwill and partnership, in particular on the mental health side for this, because that's necessary. Dennis, did you keep us going?
Yeah.
Dennis, can I just ask
Yeah.
Bob or Charlie, do you know what the outcome or dissemination of whatever happens at the meeting tomorrow will be? Just because we're meeting with people tomorrow, the whole agenda this afternoon and tomorrow is about data and performance measurement. So I think it'd be interesting for that group to know kind of that the meeting's happening and just what's going to happen with it.
I don't know.
Okay.
This is the first I've heard of the meeting, but I'm very happy to hear what's going on, and I agree with Patrick's comments concerning about the importance. And I know that Pete Delaney has that as a mindset, given his time out here a couple months ago.
Bob,
Yeah,
the question's just about what's your plan for dissemination of the import of your meeting that goes on the next couple of days.
Yeah, well, let me say, I think it is a terribly important meeting. I'm going to read the agenda and tell you it's modified based on feedback both from NASMHPD and us. And Kevin Hennessy is working with Pete Delaney on this, and there's several others from SAMHSA that are on it. And clearly, they have elevated out of each of the separate service areas, CMH, CSAP, CSAP, and are culminating all of that data at the director level. And the title of it is Developing an Integrated Behavioral Health Client-Level Data Reporting Strategy. Okay, so that's what it is. Pete's going to do a welcome. I'll do something. Rob Morrison, my counterpart, will do it. There's a facilitator, Michael Randall, I don't know him, who will be trying to help us through this. There'll be Ann Heron will talk a little bit about the block grants and the role of data. They had originally proposed a whole lot of discussion about DIG and all the other TEDs, and we said, wait, no, we want to, in fact, have some time to give you feedback on kind of what our concerns and how we want to work with you. There'll be, then 10:15, there'll be an overview of federal efforts regarding quality measurement, development, implementation. Liz Patton will be doing that. And then the next couple of hours, it's state feedback, reactions, challenges, and opportunities. We'll have a working lunch where states will actually talk about lessons learned from DIGs and TEDs and others. And I would tell you that no one is happy on the substance abuse side with feeling that TEDs currently captures what they need and they're wanting to look down the road, just as nobody's really happy with just what we were collecting on the CMHS side. There will be a section at the end of state, federal, and associates collaboration, identifying essential elements and sources for data collection and an implementation and follow through with core responsibilities. So one of the concerns we had was you have a meeting, you hear from us, and it doesn't go anywhere. So we pressed to have an ongoing process. The staffs of each of our associations will take some responsibility, and we will involve these specific work groups that have been empowered by our two associations to be the representative of our associations on these negotiations. That may be stronger. I would tell you historically, the substance abuse field has and in fact, some of the pluses of that, it led to not as much diversity in data collection, where each individual state may collect something different. As you know, we've been working for decades with SAMHSA on the mental health side, and sometimes we haven't gotten to quite where we needed to be with standard data collection across. And not a lot of money either to do that. And unfortunately, there wasn't any new money as all of you are painfully aware of, with the ACA going to mental health. But let me stop there and ask for more feedback.
Chuck?
Bob, this is Chuck McGee with WICHE, and we have data from one state that that kind of addresses one of the points that you talked about. And I just want to underline that there is a big difference between people coming into treatment for substance abuse and mental health. We have outcome data for both groups, a quality of life outcome scale that they've implemented that shows improvement from intake to 6 months later. And then your substance abuse people, if they're new clients in the system, they've not been in before, that's one story. The people that are in the system that have been in for a long time tend to be mental health and clients. And if you match those data up with Medicaid, for the ones that you can do that, then you can show that those people that have been in the system have, many more of them have chronic health conditions that you've talked about. So it just underlines exactly what you mentioned before. They do have some quality of life outcome measures in this state that show change from time one intake to time two. But if you're looking at the ongoing, you're not seeing, you see the drop initially, but you don't see the drop later. And there are reasons for that, I think.
Yeah, I appreciate that. And clearly the time one, time two, they wanted to demonstrate in the mental health that impact in short time frames, much shorter than what we experience in mental health. And in some areas like criminal justice, where the N is not that large as it is in substance abuse, and talking about the impact, as well as employment. Unfortunately, our people are not getting employment at the level we were hoping they would. So thank you. It's good to see you. I haven't seen you for a while.
You know, last year.
Yeah. Anybody else have comments?
Well, we're just running out of time, Bob. So,
well, I want to get. Can I get one little feedback? Was this helpful for you folks?
Definitely.
Yeah.
Yep.
Yes.
Okay. I hope we can do it, and I can be there next year, Dennis.
Absolutely. And Bob, just because, you know, I can't not use the Vine once I have the Vine. You know, the one thing I think that's important in this discussion that I haven't heard discussed, that we're certainly going to focus in on the next couple of days, is around the culture of data and how data is used is very different in these different sectors between general health care, mental health care, and substance abuse care. You know, just the whole culture around data, how data is used, why it's used, is very different. And when you're beginning to talk about integration, you can't ignore the culture change that's inherent in that. And I guess the point that I've been making with folks quite a bit is that, you know, when you look at the culture of especially behavioral health care, mental health and substance use, our culture is one of justification. We collect data, we tend to collect data retrospectively through archival means to justify the expenditure of the funds that we're receiving or that are being threatened to be cut. In general health care, it tends to be much more of the use of data is much more proactive. It begins at the point of care. It supports clinical decision making and total quality improvement. And usually the question of justification isn't even on the table. That's not even a part of their culture. And so I think that as we begin to bring these systems together, I mean, we have to ask ourselves, why are we collecting this data? Is it to improve the care that we're delivering, or is it to justify what we're doing? Because I think we've been, for the last 30 years, sort of trying to justify our existence, and that's sort of driven our data collection. That's just my 2 cents. Maybe a nickel.
No, I think you've captured kind of where we are, but we need to be thinking about where we go.
Yeah.
And be part of that larger health network, in my mind. So, and I look forward to the benefit of your discussion when you wrap up whatever you're able to share with us, Dennis. I sure appreciate it.
Yeah, we'll absolutely loop back to you, and certainly you feel free to loop back your information, and we'll make sure we put it up on our website and share it with people.
You bet.
All right,
Thank you.
thanks
Good
so
to see
much,
all of
Bob.
you.
Thanks, Bob.
My pleasure.
Adios.